Finals SAQ3 Acromegaly. The case. A 45-year-old male with acromegaly presents for an elective trans-sphenoidal hypophysectomy. A. What is the cause of acromegaly in this patient? Hypersecretion of growth hormone from a pituitary adenoma. B. List the clinical features of acromegaly of relevance to the anaesthetist, 45 marks. Airway. Possible difficult airway due to large lips, macroglossia, macrognathia, thickening of pharyngeal tissues, laryngeal stenosis, and narrowed subglottis. Measures. Need a plan for A, B, C, and D. Possibly need for second anaesthetist. There is a need for difficult airway trolley. Option for difficult back mask ventilation, size 6 mask and Guido airway. Difficult endotracheal intubation. Options includes awake fiber optic intubation versus awake loop versus video laryngoscopy. Prepare large blades and small endotracheal tube. Respiratory. Patients with acromegaly are prone to have OSA. There is risk of hypoventilation and respiratory failure post-operatively. Remifentanil infusion and awake extubation are beneficial. Cardiovascular issues include hypertension, left ventricular hypertrophy, cardiomyopathy with diastolic dysfunction, valvular regurgitation, ischemic heart disease. ECG changes includes complex ventricular arrhythmias and left ventricular hypertrophy. Increased peripheral soft tissue deposition results in difficult cannulation. There may be a need for preoperative transthoracic echocardiography and arterial line. Neurological issues include raised ICP due to obstruction of the third ventricle, spinal cord compression, peripheral neuropathies due to impingement by soft tissue or bony overgrowth, visual field defects due to bitemporal hemianopia by compression of pituitary adenoma. Meticulous care with padding and positioning are required. Endocrine issues include diabetes mellitus. Blood glucose should be monitored and managed with insulin intraoperatively if necessary. Consider regular ABGs and avoid dexamethasone for antiemetic. There may be hormonal hypersecretion, and there may be a need for somatostatin. There may be hormonal insufficiency and need for replacement, such as glucocorticoids or thyroid hormone. There may be central diabetes insipidus. Monitor urine output, biochemistry, such as sodium, osmolality in urine and plasma. There may be a need for desmopressin and endocrinology input. Gastrointestinal issues include increased risk of colonic polyps and cancer. There may be a need for surgery. Cutaneomusculoskeletal issues include osteoarthritis, enlarged and distorted skeleton. Resultant kyphosis may lead to restrictive respiratory defect. Bony overgrowth around joints, limited movement. Care with positioning and padding is necessary. Neurovascular compression syndromes may occur. For example, the ulnar artery, which may be compressed in up to 50% of patients. Perform Allen's test prior to radial arterial line insertion, and avoid radial arterial line insertion if there is impaired ulnar arterial circulation. Renal dysfunction may impact perioperative drug choices. C. How do the surgical requirements for this procedure influence the conduct of anesthesia? 45 marks. The use of operating microscope may necessitate hypotensive anesthesia, intra-arterial monitoring, immobile patient, either via muscle relaxant or remifentanil. Preparation of nasal mucosa with Moffat's solution or phenylephrine reduces bleeding. Periods of intense stimulation and periods of minimal stimulation during surgery. The blood pressure may be very labile, necessitating intra-arterial monitoring, and remifentanil is ideal for management of periods of intense stimulation. The patient is in supine position with head up tilt, and this may lead to potential for air embolism. Ensure adequate intravenous filling. With surgery performed on the head as a surgical requirement, the airway will be under the drapes, and the anaesthetist is distant from the airway. An armored tube is recommended with meticulous securing of the ETT and protection of the eyes. The nerve stimulator should be placed at the leg. Circuit extensions for breathing system and for intravenous fluids are beneficial. Bleeding from internal carotid or cavernous sinus may occur. It is recommended to intubate the airway and place a throat pack and ensure group and safe blood samples are ready preoperatively. Rapid emergence and need for ability to assess neurology as soon as possible post-operatively necessitates use of short-acting and rapidly reversible agents. The suprasellar portion of the tumor may need pushing into surgical field. Lumbar drain with injection of saline or controlled ventilation to ensure high to normal PaCO2 may be needed. There is a need to avoid post-operative surges in intracranial pressure, especially if CSF leak has occurred. This can be achieved by smooth emergence, adequate reversal and antiemetics, airway and CPAP for known OSA.